Hello, everyone. It's my honor to host Dr. Bill Choby today. Hello, Dr. Choby. Thanks for joining me this morning.
Thank you for inviting me. It looks like a pretty cool thing you got here.
Thank you. We had the pleasure of meeting right before one of your lectures in Kansas City when you were lecturing for International College of Cranio-Mandibular Orthopedics. And I really enjoyed meeting with you. And ever since we've collaborated on a few patients and a few of your neuromuscular and bite rehab patients. And I helped overview the anatomy and the design of your Myoaligner cases. So it's been a pleasure working with you in the past year and a half.
It's my pleasure as well. Thank you.
So to give you our listeners a little bit of background on Dr. Choby, he graduated from University of Pittsburgh School of Dentistry in 1976.
Yes.
And after graduation, he entered a two-year general dental practice residency at Brookdale Hospital Medical Center in Brooklyn. He has pursued advanced dental training ever since. He has become a master of the Academy of General Dentistry, a fellow of International College of Cranio-Mandibular Orthopedics, a master's of public administration, and a diplomate of the International Congress of Dental Implantologists. That's very impressive, Dr. Choby.
Yeah.
And yeah, you never stop learning. And he's also a consulting staff member at Excela Hospitals and has surgical privileges and dental implants at a Frick campus. His expertise is frequently called upon for second opinions for quality assurance companies, peer review panels, workmen compensation disputes, automobile accident claims, dental insurance companies, physicians, attorneys, and other dentists. And he's performed more than thousands of root canal treatments using J. Morita's revolutionary rotary handpieces and has demonstrated innovative root canal system before endodontists at the American Association of Endodontics. You have your hands in everything, doctor, from implants and rehabs to endo.
Well, I'll tell you what, dentistry offers the opportunity to go in a lot of different directions. And if you just keep your mind open and be willing to try new technologies, it's so different than what it was when I graduated. I often say that the only thing that I really kept doing since I graduated was giving my local anesthesia. Everything else has changed. And it's changed, to think of the composite restorations that are now in the 7th or 8th version. Everything has changed. And with computers, and particularly with the diagnostic stuff, with musculoskeletal dysfunction of the jaws and such, going back to Dr. Choby in the late 70s when I ran into him. All of that changes everything, and it's possible to pick these things up along the way. You don't have to just go to a graduate program somewhere to do it. You just have an interest and pursue it a little bit at a time. As you can tell from my white hair, I've been doing this for a while. So you don't have to do it all at once. You don't have to totally disrupt your personal life. You can still have a family and all those things at the same time. Continue to advance your knowledge and skills using all this exciting technology.
And that's really the beauty of general dentistry, because as a general dentist, you have the opportunity to advance in any field that you want. You can advance in oral implants, or do bite rehabilitation, TMJ treatment. Don't you agree? That's the beauty of general dentistry.
Yes, it is. There are some problems with it as well, being that, you do have turf battles, and some group of people say they know more about it than you do, but you can hold your own in those things. And that's when I do my expert testimony, like in lawsuits and stuff. You can hold your own. I think the only thing that you have to be careful of is that you have to be, when you're dealing with an issue, you have to be a comparable practitioner. In other words, a generalist versus a generalist. You can't do oral maxillofacial surgery if you're a general dentist, because the courts generally don't recognize that. But there are some turf battles in there that I see that there's a lot of advances coming on there. In fact, the American Academy of General Dentistry has a board certification for general dentists that I was originally on the committee way back when. So it's possible to expand and also pick up letters behind your name as you go. And the more letters, the better off you are, because that's what the public sees. They don't know anything about dentistry to amount to anything. They know whether it hurts or something doesn't look right, or something doesn't feel right. But when they go to the dentist, how do they choose? I mean, just think of yourself. How do you choose how to buy a car? I mean, you go by reputation.
Yes.
So, a lot of it, but You know, if you have a lot of letters after your name and you have some diplomas up on your waiting room, it makes a difference. Word gets around.
Education is the key, education, you know,
Absolutely.
and it's my advice for general dentists to
Mhm.
never stop learning, always continue on, you know, and
Mhm.
learn and learn. So tell me more about, because these podcasts are mostly focused on TMJ and headache
Mhm.
treatment. Please
Mhm.
tell us how your approach has changed or has not changed in the past 40 years that you've been practicing.
Well, I think it's been pretty consistent since the days of when I first got into the Myotronic series of lectures with Dr. J and some of the other gentlemen and ladies. Uh, I think once we figured out that there's more to it than just teeth, and that by studying muscle movement, studying muscle electronic activity and posture and things like that, we could figure out that we just can't just play around with teeth. That there's other things to consider, and even in spite of all the things that we may consider with head posture, breathing, swallowing, speech, all those things, there's also the effect of the patient on themselves. So some people that are in real high stress jobs, they can have a beautiful neuromuscular occlusion and still just tear it apart. So we have to understand the realm of it. I mean, it really is a combination of many things. And now with more emphasis on sleep disorders and things like that, it all sort of fits together. But back in the early 80s, I was doing some research on the swallowing, effect of swallowing with the neuromuscular occlusion. And I repeated Dr. J's original test, which was cineradiography of somebody chewing and swallowing. This was back in the 50s when he first noticed that there's that the mandible has to meet the maxilla in order to have, and sorry about the phone,
No problem.
in order to have a sufficient tongue thrust to force food down, the throat. Well, I repeated that with barium swallows with the radiologist back in the 80s, and it's pretty clear, with or without an orthotic, that swallow effort is twice as much, if not more than 3 times. So these people are constantly bobbing their head and their throat and their neck in order to just clear the oral pharynx. And I'm sure that there's some correlation there between people who have choking problems and need Heimlich maneuvers because they're not able to clear the oral pharynx. And so I've noticed that it all ties together. So when we talk about trying to restore somebody to where they're supposed to be, then it takes a little bit of doing to understand the bigger picture. Head posture is huge. Looking at them at the level of the eyes, things like that. Yeah, the number of crow's feet around the mouth is another example. All those things have to be taken into consideration when we think about doing reconstruction, particularly implant reconstruction, because after we take the teeth out and put implants in, the fact that an implant does not have a PDL means that there's really no feedback loop as to where the teeth are supposed to stop. So it's a different type of feel. So that's even more important, that we also have muscular balance between the elevators and the depressors and the anterior, posterior, up and down. All of that has to be within the neutral zone in order to extend the life of the implants to the maximum amount. And that's what I like about your myoaligners with the anatomy in them, because that gives me a trial. So if I have somebody, and I think, and they often come in, their musculature is very confused. The disc patterns or the disc shape could be just all over, could be folded over.
Yeah.
It could be trapped. And all of that changes once we get them into a neuromuscular occlusion, but it doesn't always stay there. You've got healing going on. You're going to get a remodeling of some of the TMJ, age dependent, So by putting them in something that's removable, something that's not permanent, we're able to really judge their response to it, see whether or not it's where they need to be. And then as far as any reconstruction goes, knowing where you're going, having a compass, is huge. It's
Exactly.
huge. So,
Exactly. Whether
that's
you're
what I
doing
like about
ortho or restorative, any kind of treatment, I've
Yeah.
always told people orthotic is probably the most conservative approach. A removable orthotic is the most conservative approach that you can address the occlusion part of this neuromuscular imbalance. I think what patients find frustrating, and most of their dentists find frustrating, is that they're only coming up with one solution for this complex, multifaceted issue. You touched on swallowing function. Just the function of breathing and swallowing correctly is huge, you know,
Yes.
and occlusion, yes, occlusion is part of it. Airway and sleep is part of it. Neck and body alignment is part. So what can we do to help these patients get a multidisciplinary approach to care? What can we do to teach our dental schools so the new graduates understand the connection between the bite and the neck alignment and swallowing and airway? You've been, you know, as you mentioned, on the litigation side and things like that. How can we change the system more that undergrads learn more about this connection?
These are the same questions that we faced back in the early 80s. There's a resistance. It's a professional resistance. And I think that, you know, unfortunately, the only way you get through some of the hard-headed attitudes about this is in court.
Oh,
And
wow.
I did a case I mentioned in my lecture. It was from a large northeastern city, where a woman had spent over $200,000 with implants, and she had basically hybrid implants, you know, hybrid prosthesis.
Mm-hmm.
This guy was a well-known, renowned prosthodontist who learned how to do surgery, you know. And he has, in the course of the discovery, he submitted his resume, which had 72 pages of articles, of seminars, of lectures that he had given, and not one of them said neuromuscular. And after he had been through dealing with this woman, who lived incidentally in Florida at great expense to return to the Northeast to have these adjustments made, he didn't have a clue about what neuromuscular was. It was just really astonishing to me. This was a guy that was, you know, supposedly very well respected. But in the very end, towards the latter part of his notes, he said, well, maybe it's neuromuscular. I had to laugh. But in the courtroom, he didn't have a clue about what muscles do. And I thought to myself, here's a guy that should know this stuff. But it's that mindset that we're a bunch of crazies out there trying to prey on the public, that infiltrates different things like licensing boards, which is huge, because people that are on licensing boards are not very bright when it comes to anything new. Many of them are on there because they have nothing else to do, or they're buddies with the politician. So it's very important that in order for us to start to see some changes, is that we have to just prove ourselves. And when we do get these unusual cases, I have an example of a case. A girl came to me who had a terrible accident, fell and broke her mandible. At the midline, as well as subconjunctival fractures. She was into open reductions and fixation for a long period of time. She's 15 years old. She's in the middle of a growth spurt. There's all kinds of stuff going on. Plus, you've got the peer pressures of being a popular girl in class, now can't eat without popping and hurting her jaw. She was at the Children's Hospital in Pittsburgh. They told her, you're going to have to live with this on pain pills.
Wow.
So I don't know how they found me, but they did. And the first thing you do, you put them on TENS. I mean, a simple BNS 40. Let's just see what's going on here. And, you know, we're starting to resolve the pain. So fortunately, I have Dr. Alexandria, not that far away, whose office is near where this gal lives. But I started her on this, the Myoaligner, and we saw results. And like the father's like, wait a minute, how can this be? Why don't those people down there at that huge university know about this?
I know.
But they don't. So eventually we were fortunate enough that I did get a call from the pediatrician or pediatric neurologist, and we forwarded some of our information to them. And this, I think that the positive side of this was that this girl's father was a real activist about getting us into the hospitals. So that's what it takes. You know, you get the one case out there, it's a head scratcher for all the disciplines, and then we can walk in with a simple answer. I mean, when I first saw this, it was in 5 minutes. I told him what was wrong with it, and he thought, it can't be. It just can't be. It's too simple. Said, well,
too simple. I know.
That's the way it is. Yeah. So that's unfortunate. I think it's just we're gonna have to let our light shine, and when we have an opportunity in a case in litigation, you know, to stand forth and just tell people what it is. And I don't know if we're gonna get any other way, because there's just such a resistance to what we do.
Yeah. I'm so glad you shared that case, because I remember that case. I think it was your first Myoaligner case, but I didn't know this touching story attached to it, that it was a 15-year-old struggling with pain and was given no option. And for people that don't know what we're talking about these segmented neuromuscular orthotics that just go over without doing any alterations to the teeth. We make these, they look like crowns, but you don't need to shave the teeth down. And we make him segmented, so when patients chew and function, because their cranial bones flex, it breaks down some of breaks some of that flexion and force on the mandible. And if the patient is like getting an implant, you know, you can kind of like restore the teeth. Kind of before restoring the teeth, you can test drive this new proposed occlusion and see if the pathological occlusion is a primary contributing factor to this case or not. So it's a diagnostic tool, and it will help you kind of like finalize your treatment in restorative implants or any even ortho, because it's segmented. When you remove that one piece, you can see how much space you need to compensate for by uprighting these teeth orthodontically. So we're actually, because I'm partnered with an airway doctor, we're doing a lot of orthodontic cases in phase 2 after Myoaligner therapy, because we don't need to restore these teeth. We can, once they're in physiologic occlusion. And you know, what puzzles me is that we learned the basics of physiologic rest at dental school. Physiologic rest is position of the mandible where all the muscles are at rest. We use that for making dentures, you know, and we all understand physiologic rest. And a bite should be only a couple millimeters on physiologic trajectory, a physiologic bite should be. So why is it that our new graduates, our dentists, completely forget the physiologic rest concept when it's the basis of our occlusion?
Yeah, exactly.
And that's the basics of neuromuscular dentistry. If the muscles are the first thing that adapt to a pathological posture, or in this case, pathological occlusion. So as you said, the BNS 40, or we use that to relax these muscles, land the mandible to that physiologic rest position, which is our starting point. And from there, you put your restorative, it's the basis for your orthodontic treatment, for your restorative treatment, or nowadays, orthotropic treatment, which we are using with bone growth appliances. That's the big thing recently in dentistry, with so much emphasis on airway remodeling that we can do.
Well, I think it's important to understand what the teeth actually do. I mean, if you ask people, all right, what do they do for you? Oh, I chew with them. Well, it's really not the case. In a listing of priorities of how the teeth interact with our body, the number one thing that they do is support the head.
Yes.
It's 24/7. And then the next thing is swallowing. How many times a day do we swallow? Thousands of times. And again, we talked about a little earlier, you have to have solid contact between the mandible and the maxilla in order to squirt everything down your oropharynx.
Yeah.
And then you have breathing. Lots of people with mouth breathing. This is why the class 2s, their chin being retruded looks like Beetle Bailey's Zero in Beetle Bailey cartoons, where he had the short chin. And actually, I say that the mouth starts to look like the nose.
Yeah.
It's open on the top. That's for mouth breathing.
Yes.
And of course, when we're running or you're exercising, you've got a mouth breathe because you need greater volume of air. But so if you have nasal problems here, or if you have a palatal shape that is not conducive to full nasal expansion and airways, going back to when we were kids, my generation growing up in the 50s, we all had these straight nipples that kids got, babies had. That led to a whole pile of orthodontics until finally the proper design came around, largely through the work of Jim Gary out in San Francisco years ago.
The Nook pacifiers. But you know what? Still at the hospitals, I've even seen pictures of celebrities' kids on a cover of People magazine or Time magazine, and they still have that little straight pacifier in the baby's mouth that they got at the hospital, which is the worst thing that you can give a child for their development.
Mm-hmm.
Yeah, you're absolutely right.
Going to the fourth function, expression. We talk, we smile, we grind. That's another function of the teeth.
Yes.
And the very last thing we do with our teeth is chew.
Yes. Yeah. I mean, how many times a day do they contact during chewing? But probably 2,000 to 5,000 times a day during swallowing. Yeah. And that's why I tell people to wear their Myoaligner 24/7. Sometimes they can take it out and chew with it. For some reason, I wear Myoaligners too. You can see it on my back teeth. for some reason, food doesn't taste the same when you have this in your mouth. So
Something
I
else
just
in
pop
there.
it out, eat it quickly
Yeah.
without it, and then put it back on. But I
Well,
know
Mhm.
the 22
that's
hours a day that I'm having that in my mouth, I know every time I swallow,
uh-huh.
my jaw is supported in the right position,
Yeah, yeah.
and it's not
Which,
retracting.
which also means that your neck muscles are
Yes.
acting properly. So there's not competition here. You know, and I can't thank you enough for coming up with that idea, because it's great. I mean, all the orthotics that I made in the past basically were, you'd have like a point of contact, but that was about it. And it wasn't very comfortable to wear. But now with the PMMAs that you make, I mean, they're small enough, thin enough that it's not as
Yeah.
much a problem with speaking or
Yeah.
anything else. Yeah.
So
I
this
mean,
is an example of the PMMA that we use because they're digitally designed, and
yeah.
you know,
Mhm.
we can have this anteriors open, kind of
Right.
like
Yeah.
Gelb appliance. This is similar to a Gelb,
Yeah. Yeah. Yeah.
but because the material is now stronger and flexible, we can have that instead of wire. We can have that, or if you need anterior clearance, you know, we can make them bigger with the anterior clearance. But really, these are my all-time favorite because they're hidden in the mouth. You can see how I'm wearing mine.
Mm-hmm. Yeah. No. Okay. Yeah.
And then you see,
These segmental. Yeah.
yeah. Now with Ortho, you can kind of see the gap between my teeth.
Sure. Sure.
And if I don't have this lift, when I go to bite down, because I have bicuspid drop off, my
Right.
mandible retracts,
Yeah.
my
You're
airway
trapped.
closes,
Sure.
and then
Sure.
forward head posture comes.
Yes. Yes.
Yeah.
Exactly.
So
It's an amazing thing. I think you're really onto something here. I was really pleased when I spoke with you in Kansas City, and I thought, now finally somebody's got that part of this whole puzzle figured out. So that's great. I
thank you.
congratulate you for it.
Thank you. The lab part of it, getting the lab and the designers to understand the concept and start designing it was tough. And we had to find some of the best in the nation and even in Canada to help us with the design. Because lab technicians are used to designing crowns for teeth that are shaved down, like a cylinder, you know, and designing these to teeth that are bulky and they're tilted was not an easy task, but we finally got it. And as you see, you can kind of like see the retention. It has good retention, and we can make it, the doctor can temporarily cement it on for the patient depending on the treatment plan, or making it completely removable when the patient actually takes it in and out. So I'm hoping, what I'm trying to do is to recruit hundreds of neuromuscular dentists to document, you know, we have come up with a 2-page sign and symptom sheet for the patients, and I'm hoping that they can help me submit this research to FICCMO to put patients in a segmented orthotic, get their sign and symptoms, and then ask them for the sign and symptoms in about 3 months. So we can have a lot of data. I think the biggest research that we have there is from Dr. Barry Cooper, where he had 300 patients in neuromuscular orthotics, and he documented. I'm hoping to even get more by recruiting other practitioners like you and document that and start publishing, you know, how effective these neuromuscular anatomical orthotics can be, especially when they're segmented for chewing and functioning, because they're not flexing the mandible.
But, you know, more important than that, you have the patient's response to it.
Yes.
Whereas they're getting positive things happening for them. I've had some patients are getting Botox for temporalis pain, you know, and I can see clearly that there's too much space, too much freeway space. That was one of the Myoaligners you did for me. That's exactly what the problem was as a young girl. And she was really tragic, all the things that she had to go through. And the neurologist saying, you know, you're going to be on drugs all your life. So, you know, wait a minute. The beauty of it is that you put them on a BNS 40 for half an hour or so, and right away you can see those results. It's better to use the J5, which incidentally I introduced back in the 80s. It's nice to see that Myotronics put that into production. But that also helps with getting those posterior neck muscles loosened up. But the thing is, we can show patients that they don't have to feel this way all their lives. And that's huge. So here's something with what they can take out or even, you know, leave in, cemented in, that's going to give them a new outlook on life. Because this truly, for a lot of these people, this is life-changing stuff. This is huge. And their personality changes. They feel like, you know, rotten all the time. They become isolated. I mean, I have known of a couple cases of suicides, and it's tragic,
That is
really
tragic
tragic.
that we have such a simple solution to it, you
Yeah,
know, and there's
yeah,
people out there that have to commit
yeah.
suicide because of the chronic pain and suffering. It is,
And nobody tells them what's wrong with them. And here, the problem is you got too much space between your teeth. And
yes,
well, you can't see space unless you know what you're looking for. It says,
exactly.
well, they look okay, they fit, they seem to fit okay, but the problem is that there's too much space.
Yeah. It's
And that,
amazing how 1 or 2 millimeters in the mouth, how
Mhm.
it exaggerates into pain and discomfort into head and neck, you know, and
Well, it's
major
just,
malalignment of the cranial bones.
well, it's repetitive trauma that causes it. At a histologic level, the repetitive trauma eventually gets to a point. And I always equate these little things as like you have a pebble in your shoe. I said, boy, it's just a little tiny pebble. You stand on that all day long, it's going to hurt. And
Yes.
it's just a continuous repetitive thing. And then once you have histologic injury and things like that, particularly the ligaments and so of the joint, that's very difficult to resolve unless you get them into a point where you can get full flushing out of the muscle, the lactic acid out, and all that sort of stuff.
Mhm.
And that can only happen when you have some target. Otherwise, to them, it feels normal that our teeth fit together a certain way, even though it's bad. It's a bad bite, but it feels normal to them. So you have an engram here, an engram of being a pattern of muscular contraction,
Yes.
sort of like signing your name, and I call it an occlusal signature. You're used to signing your name a certain way. If you had to switch to your other hand, it would be very difficult. Well, there is a jump here that in muscle learned behavior. But the thing is, when we get them away from destructive learned behavior and get them into more of a neutral zone where they can relearn the occlusion, get a new occlusal signature to where it's healthy to the musculature and the joints, then you'll see a dramatic difference in their attitudes and towards their whole outlook on life in many cases.
Yeah.
But it's
Because you're
because it's the space.
reprogramming. Yeah. Reprogramming the muscles,
Yeah,
reprogramming the joints.
yeah,
Yes.
right.
Yeah.
And there is a bit of a learning curve there too. So there's some frustrations maybe at first. My experience has been that right away they're just elated that somebody found something wrong, but after a couple of weeks they start slipping back into their old patterns, and that's where we just have to stay with them and encourage them to stay the course on it. This is what's happening,
Yes.
and if we can get them through that, and then often they'll come back and say, "Look, I just want them all fixed, full recon." Well, that's a whole nother story. But the fact is that we can get them somewhere with your Myoaligner. That's predictable. It's not permanent. It's a huge advantage to what we used to use in the past, and I commend you for it.
Thank you. And I think it buys them time in the 2-3 months in phase one, you know, that they can now that they're learning about it, they can maybe improve their swallowing. They can look into their tongue function with a myofunctional therapist, relearn how to swallow correctly. It
Mhm.
can, while they're in orthotic, you know, they can learn swallowing with it. They can look into their airway and sleep apnea. They can look into their posture, craniosacral alignment. Patients need to understand that they need to, all these years, 30, 40 years, their body has been going through a lot of torsion, and we're unwinding that. So they cannot expect that with 1 or 2 appointments at the dentist, all the pain will go away. They need to
Still there?
understand how they're connected.
Yeah.
And
Well, there's another component of this. I don't mean to interrupt you there. We had a little glitch. It's the neurologic component. I went to John Hopkins Swallowing Center way back when I was looking into this stuff, and I have some video of it. But in talking to the specialists in swallowing disorders, because there are people that have strokes, that they'll have the ninth cranial nerve will be compromised and they can't swallow. So by using a TENS, by using this diagnostic equipment, we're able to rule out a lot of medical problems. I can think of two offhand. One, a lady had an autistic neuroma that was coming out as pain in the ear, pain in the jaw. And she did have a click and pop and joint, but once I got her into a TENS, she says, everything feels pretty good, except I still got this problem. Sent her to ENT. Here she had a little tumor growing in her ear. Another patient, an older patient, pain in my jaw, pain in my, down through my throat. Put her on a TENS. As a rule out, we could figure out whether or not this was her problem. Well, it wasn't. She had obstructed carotids. She had to go in surgery and have her carotid stripped. That could have been a life-saving thing.
yes.
And then on the other extreme, I have to share this with you because most people probably never encountered this. I was consulted once on a case where a girl was totally locked down. I mean, this is what you'd call like when you get tetanus, lockjaw.
Mhm.
She was locked down, totally locked down. An oral surgeon sent her to me. And I thought, well, I'm going to TENS and see what happens. And she was just totally locked down. We had to take her to the OR, an anesthesiologist. He was reluctant because how do you get an airway when they're locked down? We had to use the nasal tracheal tube, but we had to hit her with a nectine to basically totally paralyzed her to break the spasm. And then while she was in the OR on the table, and I was able to make some sort of appliance for her and got her on the TENS. So it's entirely possible. If you think of that as an extreme example of what muscle contracture can do, and this was just a progressive injury to those muscles, but being able to recognize that at an early stage and getting somebody into something, at least to be aware of what's going on, is crucial. Going back to swallowing real quickly, and I'm taking up a lot of your time, but we can test our patients. I developed a swallowing test years ago. It's really simple. Give somebody a glass of water. Say, could you please take a drink? Okay. Watch how many times they swallow, and watch what happens to the purse string lines on the lip. Just take a swallow. Okay. If you see them swallowing 2 or 3 times, and you do it again, do it again. If you get that repetitive, this is the way they swallow 2 or 3 times, ask them, do you have trouble swallowing? Oh, yeah. You sore down here? Yeah. You feel like you're choking? Oh, yeah. Now then you say, look, now we're going to make an orthotic for you, or the Myoaligner, and put it in. Say, okay, now let's try that with this in, see what happens. You'd be amazed. You'll be amazed how much of a difference. And it's so simple to do. But it tells them that, yes, there's really something to this on the spot. It's not like, well, we already tried this. The orthodontist did that. On the spot, they can see the difference in how their mouth works just by swallowing.
Wow.
Just a glass of water. Try it sometime.
I will. Thanks for the advice. Well, I know
I'm glad I'm able to share it with you. Because,
Thank you. I learned so much from these podcasts. It's amazing. And I hope patients and even practitioners take time and watch these podcasts, because there's just such wealth of knowledge, from people like you.
Sure.
What is your advice for younger dentists? What should they look into? How can they benefit their patients long term?
I think the most important thing for a new dentist to learn to spot is an occlusal flag. Do you know what that is?
No.
When you, most of the time you see it on the lower incisors, wear facets. We used to call them occlusal flags. And yet they close. They don't seem to hit there. But somewhere along the stroke of that mandible, they're hitting there. And over time, of course, they wear them down. If we could just teach them that, look, when you see a wear facet, it's going to line up with something that's in the way. And that tells you a lot about them. And very simply say, okay, let's just line those 2 wear facets up. Like say you got one on the bottom and line it up on a front teeth. Now, what does that tell you about what's going on? Well, it says it's getting in the way.
Yes.
The tooth is wearing down because it's in the way. Well, why is it in the way? Well, the back's not touching. Okay, why is the back not touching? Well, have them swallow. The tongue's squirting out there. Oh, gee, what do we got going on here? What about the palate? But those wear facets are very simple to teach. Look what you have down here, this little abrasion area. Why is that the case? Or the cuspids. If you've got those wear facets on the cuspids, if we could just teach that, they'll start to wonder, why is it there?
Amazing. I said, no, I don't know what that is, but I ask my patients in every hygiene exam, I grab a mirror and I say, bite down and now slide your jaw forward. And when they slide the jaw forward, those occlusal wears just perfectly match. And I ask them, I'm like, your teeth don't mesh here. Then why do you think you have that wear pattern, And it starts them to think. And they're like, oh, wow, and then they come forward, you see the pattern. And as soon as they deviate side to side, you can see that the canines are flat, perfectly meshing. And that is exactly why the teeth are in the way of their mandibular path of closure. Sure. They're on the neuromuscular trajectory. So they have to retract back to get their back teeth meshed together. That way they can swallow, and that can the chronic repetitive motion can really break down their muscular and TMJ, and all of that structure. So
I'd be curious to ask graduating dental students what that means. What's an occlusal flag? What is that? What's that? Tell me explain that.
Yes.
That'd be really funny. I think it would be so intriguing that they would have to think about things differently. Unless they ignore it.
Yeah. The other thing is abfractions that you have at the bicuspids. That shows how much flexion of the teeth is happening during occlusal function or benching and grinding. Yes.
Yeah. Good stuff.
What is your advice for patients that are seeking treatment? How can you give them peace of mind that there is help out there, you know, and what should they look for in a dentist that is claiming to be treated?
Well, this is where we've had this conversation before. The general public doesn't know the difference between one and another, one dentist or another. They assume that everybody knows the same, and you know yourself that's not true. Even two different graduates from different dental schools will have different views about things, about occlusion or about a lot of stuff. The strength of their interests throughout school, if they're interested in oral surgery, they're going to look at oral surgery stuff. Orthodontics likewise. So I think that what patients need to look for is credentials. And I got to tell you, I've got enough behind my name, probably more than in my name. When I became board certified for implants and I started to advertise that, it made a big difference because no one else had it. And I think that with neuromuscular dentists, we need to develop a board certification. Because I get patients from a 60-mile radius. And it's because when they go online and they look at my patient reviews and they look at my credentials, they're willing to travel 60 miles to come to see me.
Yes.
But if I didn't have that information out there, and if I didn't have those credentials out there, they'd go to maybe somebody down the street. Mm-hmm. So it's really important in order for us to get into the marketplace of ideas that we have to be able to accurately reflect what we know and what our credentials are. And having board certification for neuromuscular dentists would be a huge step forward. Mm-hmm. And I think we ought to, in spite of the politics of all the ADA and all that sort of stuff, forget it. Just go get it done, and go and tell the world about it. Because if we can help that one person out there is suicidal by finding somebody who's got that, a diplomate in neuromuscular pain, then we made a huge difference.
It was worth all the swimming against the mainstream. It's definitely worth it when you change people's lives every day. I see that, yes. And now that we're actually more aware of what causes this, and we're addressing the problem in 8-year-olds, 4, 5-year-olds who are not swallowing correctly, and we know by the time they're 15 or 16 what's going to happen. It's so rewarding because you can change kids, or you can improve their functions so quickly.
Absolutely. Well, I commend you for what you're doing. It's wonderful.
Thank you. Well, thank you so much for your time. I know you have a busy practice, and yes, so we'll have this information available to both dentists and patients. Thank you.
All right, great. Good talking to you.
Have a great day. Bye-bye.
Bye-bye.